Welcome, everyone. Thank you for coming to our presentation on a novel wellness program to address physical therapy student well-being. I'm very excited, and I know my group members are very excited to present this. This is something we worked long and hard on, and a project we took uh, from just an idea on paper to results and analyzing those results and developing a poster. So we are very excited to present today. Our research group was led by Dr. Caspin and Dr. Carter. My name is Eric Holshouser, and then I'll also be presenting with Elizabeth Karr and Alea Vick. So to introduce our study and to frame our discussion here, the Centers of Disease Control defines well-being as a high level of positive functioning in the physical, mental, and social domains. And what we see is that well-being is correlated not only to feeling better, but improved work performance, relationships, mental health, physical health, and behavior and cognition. The problem that we're facing is that graduate students, when they come to PT, specifically PT students, they come to PT school. I'm sure many of you have experience with this. They're leaving a lot of their support systems. They're adjusting to a much more rigorous program in a new city, trying to form new social relationships. And a lot of studies have shown that graduate health students actually are at risk for problems in well-being. So what the studies have shown is that, and these are graduate health students, not just graduate students in general, shows 6 times higher rates of depression and anxiety. 40% are overweight in one study, 19% had elevated cholesterol, 41% reported depressive symptoms, 28% had elevated anxiety. And then, of course, we're all passionate about the physical activity, is that 66% don't meet the recommended amount of 150 minutes a week of physical activity. And when we started looking at this problem in the literature, there's very few studies looking at student well-being in medical schools and interventions to address it. And we did not find any other studies on doctor of physical therapy student well-being. What we did find in the literature is that facilitated discussion groups have been proposed as a way to improve well-being of clinicians and students, and healthier clinicians and clinicians with higher well-being improve patient care because they're more likely to address the patient's wellness needs. And also another benefit is preventing clinician burnout. So what we did is we designed a novel program to support the wellness of DPT students in our program using peer-led goal setting and habit formation discussion groups. So for the aims of our study, this is a pilot study. It's the first time we've looked at this, so we really wanted to get a wide range of outcomes to see what impact our study was having. So our hypothesis is that participants of this 10-week program will demonstrate improvements in the following measures. We looked at subjective well-being, mental health, self-efficacy, perception of academic performance, the biometrics of heart rate and blood pressure, executive function, emotional intelligence, and perceived support from the DPT program. So for our methods, we recruited 9 DPT-1 students that we split into 2 small groups of 4 or 5 students, and those groups were facilitated by DPT-3 students. And they went through a 10-week program over video conference. The program started with a 90-minute introductory session where we went over foundations of wellness and facilitated the students in developing their own vision for their well-being and helping them identify their values. Then from then, we went through 9 30-minute weekly discussion groups where we guided the students through assessing their own well-being, developing SMART goals, and working on improving their habits toward their goal each week. And to build off what we have already learned in the DPT program in interprofessional communication, we used motivational interviewing techniques throughout the sessions. So to look at outcome measures, like I said, as a pilot study, so we really tried to get a wide range. For biometrics, we looked at heart rate and blood pressure. We used the general self-efficacy scale, the trait emotional intelligence questionnaire. For depression and anxiety, we used the PHQ-2 and GAD-7, which are well-established screening tools. For stress, the perceived stress scale. For the Stroop test, for executive function, we use the Stroop word color test. So that measures reaction time when a participant sees a word, and the word will be the word of a color, and then the color will be either colored the same color as the word or a different color. So for example, the word blue could either be blue, the color blue, or the word blue could be the color red. And it's designed to kind of interfere with the participants' cognitive processes and help address their selective attention. We looked at self-perception of academic performance. Another validated measure of subjective well-being is the well-being survey. And then we also asked Emory DPT specific questions. So to look at the structure of our program, we did repeated measures where we did a pre-test before the intervention, and the intervention was 10 weeks long. Then we did a post-test, and then again, 10 weeks after the post-test, we did another assessment. And each of these assessments involved the biometrics, the Stroop test, and then the survey, which included the validated outcome measures as well as the Emory DPT specific questions. And then I already covered this a little bit, what the sessions look like. Introductory session was foundation of health and wellness information. So these are your basic health recommendations. We also went over the Blue Zones lecture by National Geographic. And then from then on, the weekly discussions, they looked more at assessing well-being, exploring their readiness to change, developing SMART goals, and then each week preparing for action and making tweaks to their plan as necessary. And also after the intervention ended, we did a debrief session where we got feedback from the participants and also kind of reviewed what we all learned over the course of the 10 weeks. So for our results, published here are the statistically outcome measures from our repeated measure analysis, and we use the Friedman test with a threshold of 0.05 for the p-value. And to orient you here, what you're looking at is the mean with the error bars of standard deviation for pre-test, post-test, and follow-up. And first, we're looking here at subjective well-being and impact of the DPT culture. So starting on the left, what we saw is an increase in perceived support from the program during the intervention. Then it dropped down afterwards at follow-up. Same thing with subjective well-being in the subjective well-being in the physical well-being subscale of the well-being survey. So pre-test to post-test, we saw an increase, and then back down to baseline at follow-up. We saw resting heart rate actually increase throughout the program, which we have several reasons to speculate why that I won't go into right now. Some more results for blood pressure. We saw that stay relatively the same through the program versus with diastolic and systolic. And then actually there's an improvement in blood pressure at follow-up. For the Stroop test, we tested both the congruent and incongruent conditions. So congruent is when the color and the word match. Incongruent is when the color and the word are not aligned. And this, we saw an improvement from pre-test to post-test, and then the improvement was maintained at follow-up. We also, for the rest of the results that we have a complete table of results that you can look at if you scan your QR code here. For the sake of time, I won't go into detail of those, but generally we saw a trend of improvement from pre-test to post-test, and then a decline from post-test to follow-up. Although, like I said, these on the poster are the only statistically significant measures. So as far as the discussion, what our repeated measures analysis showed that in the short term, like during the intervention, there was improvements in physical well-being, perceived support of the DPT program, with regard to physical and professional well-being, an increase in heart rate, and improvements in cognition as measured by the Stroop test. Although we only saw a persistent effect for the Stroop test to follow up, and then blood pressure, like you saw, showed that decline after the intervention. And one thing we speculate that could have been contributing to this is students self-selected their goal and the activities to reach those goals. And what most students, regardless of the domain of their goal, is they chose physical activity to address it. So, this may have influenced the larger effect size in cognitive performance and physical well-being. And this is consistent with the established literature. As you know, Dr. Nocera and many others have done studies on the link between cognition and physical activity. And it also might speak to the fact that significant improvements in 10 weeks, you need to really see a targeted intervention. Additionally, we saw a lot of anecdotal evidence from participant interviews. So these are things we didn't directly measure in the study, but we felt like students reported a lot of added value. So one thing is improved sleep quality and quantity from some participants, and then they also reported deeper social connections. So I think there's an opportunity for future research to further explore these benefits and those relationships. So in conclusion, participation in the described intervention may improve physical well-being and executive function of DPT students. There also may be improvements from this type of program to perception of the DPT culture with respect to physical and professional well-being. And we feel, as far as the implications of this study, is that further development of these peer-led wellness programs can be a solution to address the widespread need to improve student well-being and hopefully develop thriving clinicians in Doctor of Physical Therapy education. Thank you all so very much for listening, and we'll open it for any questions.
Well, I have a question. I might have missed it, but actually two questions. One, how long was the follow-up after the conclusion of the program, which is wonderful. Yeah, excellent project, you guys. And two, you said you used repeated measures tests. What tests did you actually use that you found these statistically significant differences? Because you got such a small
Yeah. So to answer the first question, the follow-up was 10 weeks after the post-test. So it was basically pre-test to post-test was 10 weeks, and post-test to follow-up was 10 weeks. We tried to keep that consistent. And then the repeated measures was based on the mean and standard deviation of the outcome measures, and we used the Friedman's test to look at across all 3 time points.
I have been having.
Dr. Costin, do you have a question?
No, I'm so sorry. Go ahead, Eric.
Sorry. To look at between specific time points, we use the Wilcoxon rank sum test.
Thank you.
Well done. This is just fantastic stuff for us to be looking at as a program, and what a great project you guys did trying to help your fellow students. Just a question about the Stroop test.
Yeah.
Improvement at both both follow-up periods. Is there, in the Stroop test, is there anything in the literature that shows that if you practice that test, you improve on it? In other words, are we seeing true improvement within discrimination, or is it maybe a product, the improvement could be a product of the fact that they've taken the test previously, so they kind of know how to do it?
Yeah, that's possible and something we talked about. We tried to control for it the best we could. What we did is we had them take one practice test. I believe it was 1 minute long. And then they did like a 5-minute Stroop test. And then they didn't take it again for 10 weeks. So, it's possible from I guess, 2 quick sessions back to back that you could have seen a practice effect. But we feel like there was like adequate time, assuming none of the students went and practiced on their own. I imagine that they would be too busy to do that and had a lot of other stuff on their mind. So we feel like that it's possible that could have had an effect, but we feel like we also controlled for it pretty well.
Dr. Blanton, I saw you had a question.
Yeah, thank you, Leah. One, just to applaud you on this really important project. I mean, and to underscore really I think the foundational work that was done to sort of leading up to it, and why it is so important across, in the nation. So I'm really kind of proud of this you guys being a real leader for a model for sustainability and wellness. So when I'm thinking about what you did and the actual intervention, do you mind telling me a little bit more about what you felt like was a theoretical construct behind what you specifically chose as to do in this 10-week intervention, or just some of the evidence behind some of these activities that you chose, and even the time duration?
Yeah, so the way we designed it was kind of a combination of what's been shown in the literature in the past to work, and then also adapting it based on student needs and what we felt like specifically the DPG students in our program would respond best to. So, we looked at the motivational interviewing literature, which shows effects on a variety of health outcomes. We also looked at different health models, and then different peer support and behavior change plans from other medical studies from other medical schools. And we kind of took bits and pieces of each of those of what we felt could fit into a 10-week program. As far as the length of the program, we wanted it to be able to fit into 1 semester, and we wanted to try to make it as long as possible in order to see effects, but like I said, keep it within that 1 semester window. And also, we've seen, when we were looking at the literature for things like cognitive performance, a lot of the studies looking at physical activity and executive function, those showed improvements in 6 to 12 weeks.